Dr. Carol Wagner is a board-certified pediatrician and neonatologist at the Medical University of South Carolina and holds the rank of Professor of Pediatrics with tenure. Dr. Wagner received her undergraduate degree from Brown University and her MD from Boston University School of Medicine, with training in pediatrics and neonatology at the University of Rochester, New York. She came to the Medical University of South Carolina in 1992, and for the past 24 years, Dr. Wagner has partnered with Dr. Bruce Hollis to conduct vitamin D research, completing 3 large randomized controlled trials of vitamin D supplementation during pregnancy and 2 additional pilot studies, contributing to a larger vitamin D supplementation randomized controlled trial involving lactating women and their infants. Grassroots Health is honored to have worked with Dr. Wagner so closely over the last several years, and we welcome her today for this important presentation on vitamin D and prenatal health.
Thanks, Jen and Grassroots Health, for inviting me to give this talk on vitamin D deficiency, the canary in the coal mine, the indicator of suboptimal health in pregnant women. It's really a privilege to talk about something that's near and dear to my heart and really important. As far as disclosures, I'm going to be talking about studies that were partly supported by the National Institutes of Health, Thrasher Research Fund, the W.K. Kellogg Foundation, Grassroots Health, and the South Carolina Translational and Clinical Research Institute at the Medical University of South Carolina, MUSC, that was supported by a grant from NIH and NCATS, as well as the Stone Foundation of the Children's Hospital Fund of MUSC. And I have no financial conflicts of interest to disclose that are relevant to this talk and project. So really, what I'd like to review during this talk are the following objectives, learning objectives. Number one, let's focus on pregnant women and really go over some of the compelling data about maternal health status and outcomes in the US, as well as globally. And then let's talk about the root cause analysis of poor maternal health and general health in the US. Review the 6 pillars of a healthy lifestyle. Focusing on lifestyle, diet and lifestyle, what is the relevance of vitamin D deficiency? And I think you'll come to see that it really is the canary in the coal mine. Here, I'd like to review the vitamin D intervention studies, just a few of the many, and why just being vitamin D replete does not make one achieve optimal health. And really end with some questions, some compelling questions. What can we do for the future and integrating wellness into everyday living? Okay, so as you all know, pregnancy is a time of challenges. There certainly are bodily changes, an array of hormonal changes, and immune challenges for both the mother and her unborn child throughout pregnancy. And when we talk about the first 1,000 days, that's from preconception to 2 years of age. And many factors affect those outcomes. The first year of life in particular reflects a crucial stage for immune development of the infant, and as you can imagine, influences the child's future susceptibility to all sorts of challenges, including infection and immune-mediated diseases. There are countless exogenous and environmental exposures that impact both the immediate health and outcome of pregnancy and influence multiple aspects of development and lifelong health of the offspring, and also the mother during her pregnancy, that have really compelling longitudinal effects. One of the publications that came out in 2021 that was commissioned by the Commonwealth Fund, entitled Mirror Mirror 2021, Reflecting Poorly Healthcare in the US Compared to Other high-income countries. And what you see, if you look at the very bottom, is that when we look at compared to other high-income countries such as Norway, Netherlands, Australia, the UK, Germany, New Zealand, Sweden, France, Switzerland, and Canada, we are at rock bottom. We have the worst health system performance using objective measures. Yet we spend the most of any of these countries. So why do we have such poor health in the US? And then if we look at it another way, maternal mortality in the US far outstrips that of other industrialized nations. We have the highest maternal mortality on the globe in these industrial nations, and that's clearly looking at deaths per 100,000 live births. We also know that in the US, we have chronic disease and really astronomical healthcare spending. So US healthcare spending grew in 2020 by 9.7%. Much of this was attributed to COVID-19, but it continues even post-COVID. We spent 4.1 trillion total, and that's on average about over $12,000 per person. And as a share of the gross domestic product, healthcare spending was 19.7% in 2022, up from, 2020, up from 17.8% in 2018. And again, trillions of dollars spent in the US on chronic and mental health conditions. And you can see the graph on the left really showing that. And if we focus on healthcare and social disparities, Black women face 3 times the maternal mortality rate as white women. And you can see this here. This was from the CDC. So the rates of death among Black American mothers, 55 per 100,000 live births compared to 19 in white mothers and 18 in Hispanic mothers. And this is just another graph showing, again, the rise of maternal mortality rate. And that continues. It has not leveled off. And I, as a neonatologist, I'm reminded of this every day in our neonatal intensive care unit. It really is disturbing. And you can see here, again, another version showing the health disparity and that Black American moms have the highest mortality. We see this also, we see it across the age spectrum of pregnant women. And then in terms of mortality, 22% occurs during pregnancy, 13% on the day of delivery, 12% on 1 to 6 days postpartum, 23% 7 to 42 days postpartum, and 30% after 42 days. So attributed much of it in the last part. So this is looking up to 1 year, 365 days, attributed to maternal postpartum depression. So what can we do to change this trajectory? Really important question. Well, let's look at modifiable influences on health. A big one, stress. Another one, environmental exposures, including smoking. Third one, higher BMI. Another, sedentary lifestyle, not exercising. Diet, hugely important. And lastly, sleep quality. So let's focus on lifestyle, diet, and the impact of vitamin D status. Really, really important. So why is vitamin D important? Well, it certainly is a pre-pro hormone. And most of the vitamin D that we make in our bodies through sunlight exposure, we see in our skin the conversion of 7-dehydro cholesterol, and there is it becomes pre-vitamin D3, and a thermal conversion in the skin becomes vitamin D3, which is cholecalciferol. We know that there are plants and fungi are potential sources of vitamin D2, which is ergocalciferol, but really 90% of the vitamin D that we have in our bodies is generated from sunlight exposure. So if you have no sunlight or limited sunlight, or you have darker skin pigmentation, you're going to need more sunlight exposure to get adequate amounts of vitamin D. We know there's a conversion in the liver of vitamin D, whether it's cholecalciferol or ergocalciferol in the liver, where that is converted to 25-hydroxy vitamin D. And then in the kidneys, the CYP27B1 conversion, it becomes the active hormone 1,25-dihydroxyvitamin D, so also called calcitriol. So that is the classic endocrine effect, influenced by parathyroid hormone and FGF23. But you can also have extrarenal conversion of vitamin D and 25-hydroxyvitamin D, particularly in monocytes and macrophages. So historically, what was touted about vitamin D was that it influenced bone metabolism and calcium homeostasis. Absolutely, it does. But it also has other effects, antimicrobial, anti-inflammatory, and anti-cancer effects. So vitamin D deficiency has a paracrine, intercrine, you'll sometimes hear autocrine effect on other non-calcium, non-bone tissues. And it's really hard to study that because it can have long latency effects. It may not be that the effect of deficiency shows up until years to decades later. We also, if we focus on pregnancy, which is really the intent of this talk, we know that the transfer of vitamin D occurs across the placenta. The primary form of vitamin D that is transferred to the fetus is calcidiol, or 25-hydroxyvitamin D. But we also know that the catabolite of vitamin D crosses the placenta to the fetus. And we also know, so about 27% is in the form of 24-25 hydroxyvitamin D. 5% is 25-hydroxyvitamin D, and 5% is 125. The fetus has the capability to convert 25 to 125. And we also know that there is an exchange between the placenta and the maternal intravillous space and circulation. And this was a wonderful article by Ashley et al. That was published in eLife in 2022, and I suggest you look at that source. So what is the role of vitamin D in the placenta? That is a huge question, and we think it probably has an effect on immune function and preventing the graft versus host disease, which can manifest as preeclampsia and vasculitis in pregnant women, because 50% of the fetal genes and tissue is foreign to mom, is non-maternal, it's paternal in origin. And so that is our working hypothesis. We certainly know epidemiologic studies looking at vitamin D in pregnancy. This is a wonderful slide from Martin Hewison. And we know that vitamin D deficiency is linked with miscarriage, preterm birth, bacteriosis or vaginal bacteriosis, gestational diabetes, and preeclampsia. We know that we can see effects of vitamin D deficiency on fetal development, neuronal development, neonatal immunity, later asthma, psychiatric disorders, and we know also neurodevelopment, and there are emerging studies. We also know that there's a link with the biological clock and the aging of the fetus. It's linked with also gestational age. So what is vitamin D? In all essence, it's a potent enabler. Um, really, it is a potent enabler of numerous genetic processes and immune function. And the late Robert Haney really I think articulated this. If you have the privilege to have heard him speak or have read his writings, he really, I think, expounded in a really eloquent way that the role of vitamin D. It's, as I mentioned, synthesized in the skin following UVB exposure with low levels from dietary intake. And deficiency during pregnancy is common. I'll show you some slides in a little bit about that. We know that clinical trials of vitamin D supplementation in pregnancy have shown that its most beneficial effects or trends for reducing these risks, and I'll show you some data about that. And I'll mention in passing really a study that was a prospective trial out of Harvard. It was a multi-center trial that really was intended to reduce the risk of allergy and wheeze in those offspring of women who had a great deal of risk. So we'll go over some of those data. So I mentioned that that vitamin D deficiency is really quite common, even in areas of the country in the US that are sunny. When we looked at vitamin D deficiency more than 15 years ago, during all times in pregnancy, it tends to be very stable across pregnancy unless a woman supplemented. But even in South Carolina, which is latitude 32 degrees north, in over 1,000 moms, what we found overall was that more than 50% had what we consider vitamin D deficiency, less than 20 nanograms per ml. So for those of you who use nanomoles per liter, that would be less than 50 nanomoles per liter. What we consider insufficiency is less than 32 nanograms per ml. And you can see that really overall, most of the women were either vitamin D deficient or insufficient, with the greatest risk among African American women. More than 75% of moms who were Black American in this study had our definition, met the definition of vitamin D deficiency, and 33% of Hispanic women and 22% of white Caucasian women. It's not just limited to the US, however, and vitamin D deficiency is a global problem. You can see that in higher areas of higher latitude, there's greater deficiency, but in areas in the world, even around the equator, where there is more access to sunlight exposure, we see really profound deficiency in areas where dress, covering skin, can lead to really profound deficiency. And you can see what we define as profound deficiency, less than 10 to 12 nanograms per ml or less than 25 to 30 nanomoles per liter. And this was published in 2012. We do not see any differences really globally. And the idea that you don't need to check a woman's level or, her total circulating 25 hydroxy vitamin D, you really need to know where you're starting. If we were recommending globally supplementation, how do you know if a woman is reaching what we think is optimal levels? And I'll show you in later slides that we have evidence where optimal is 40 nanograms per ml. So that's 100 nanomoles per liter. What else happens during pregnancy in 3 major vitamin D changes? There's adaptation in vitamin D homeostasis. There is an almost immediate increase in maternal calcitriol. And we see this to levels that are 2 to 3 times what you would see in a non-pregnant adult. And we also know that maternal 25-OHD availability via the placenta is optimal for fetal and neonatal 25-OHD status. And we also see during pregnancy an increase in maternal vitamin D binding protein concentrations. And we certainly know that there are genotype differences that can affect the concentrations of 25-OHD concentrations throughout the body. So, importance during gestation. Vitamin D is active through hepatic and renal metabolism. As I mentioned, both maternal and fetal levels, there are higher concentrations of the 125 dihydroxy vitamin D or calcitriol. And we think, as I mentioned earlier, this is thought to have immune effects. There's transfer of calcidiol or 25-OHD across the placenta. We also know that 24-25 hydroxy vitamin D crosses the placenta. There's also, transfer from the placenta to the mother. So there is really this whole connection between mother, placenta, and fetus. As I mentioned before, calcitriol is the active form of vitamin D made in the kidney. It's also the most common form used in clinical practice in renal patients or those who lack the 1-alpha hydroxylase to convert 25-OHD to 125. You need a working placenta, however, to have the 25-OHD cross the placenta. It's not the active form really to in any real great concentration, or the parent compound of cholecalciferol or ergocalciferol that crosses the placenta. And as I showed, vitamin D deficiency is a worldwide problem. We see, depending on the regions, 18 to 84% deficiency worldwide. I've mentioned that deficiency is higher for those who are living in northern climates, higher latitudes, with inadequate sunlight exposure, darker skin pigmentation, living among high levels of air pollution, higher BMI, if they have chronic GI malabsorption, for example, Crohn's disease, cystic fibrosis, eating a Western diet. Most Western diets provide less than 10% of your vitamin D stores. And then, as I mentioned also earlier, your vitamin D binding protein allele, whether you have the 1F genotype or the 1S, influences how your vitamin D, your carrying protein, gives up the vitamin D to other cells. Well, we know in 2024, the National Academy of Sciences and the Endocrine Society partnered, and they published the guidelines saying that 400 international units to 600 international units a day is adequate for pregnant women, excluding any of the studies that were done in the US or any country that had randomized controlled trials using anything. They excluded any study that had control as what's in a prenatal vitamin, 400 international units a day. All of those studies were excluded. They did in their review and their strength of the literature say that up to 5,000 international units is safe. So just to give you context, as a neonatologist, we've been giving for decades neonates 400 international units a day of vitamin D3. That gets their level to about in the 40s nanograms per ml. That's regardless of weight or gestational age. So on a per kilogram basis, assuming a 3 kilogram infant, that's 133 international units per kilogram. And for a pregnant woman, that's what is in a prenatal vitamin typically. That would be 6.7 international units per kilogram. So if you look at our data in our control group, which was what they were getting was every mom got a prenatal vitamin containing 400 international units or plus a placebo or a, a treatment bringing her the daily concentration up to dosage up to 4,000 or 4,400. And I can tell you that 400 does not change, 400 IUs per day does not change a woman's level. We know that they also recommended empirical supplementation based on preeclampsia and gestational diabetes risk. Preconception is not mentioned, but could be a risk factor. Again, let's think about the first 1,000 days concept. So also the National Academy of Sciences and the Endocrine Society said, no need to test. And do the data support this? Let's look. So now I'm going to really talk about the role of vitamin D during pregnancy, optimizing outcomes. We know there were tons and tons of data that have been amassed, epidemiologic data that suggested women who are vitamin D deficient have higher risk of maternal preeclampsia, increased risk of preterm birth, increased risk of gingivitis and periodontal disease, impaired fetal growth, impaired dentition, enamel hypoplasia in the fetus, increased risk of RSV, neurodevelopmental differences. So that set the stage for really one of the initial randomized controlled trials that was sponsored by NIH and the National Institutes of Child Health and Human Development. Our trial began in 2004 and was completed in 2010. So it was funded in 2002. We were acquired the first time in the history of a vitamin because the FDA considered vitamin D a pre-pro-hormone. We had to have an IND. And so that delayed the onset of this randomized control trial. And we finally had our first subject enrolled or participant enrolled January 6, 2004. We really completed our trial 2010, published in 2011, and then published another paper on the skeletal, non-skeletal, and birth outcome effects in 2013. This was a randomized controlled double-blind placebo trial. Women were enrolled less than 16 weeks of gestation. They had to have a singleton pregnancy. Those with any underlying diabetes or hypertension were not eligible to participate because there was concern that vitamin D at 10 times what they thought was the ideal dose was a potential teratogen, we had to stratify. So if a woman had her initial level less than or equal to 40 nanograms per ml, she could be randomized to standard of care, 400 international units, 2,000 or 4,000 international units of vitamin D3 per day. And we had to substratify by race ethnicity for the three major race ethnicity groups in Charleston, South Carolina, which was Black American, white, and Hispanic. We also, if a woman had a level greater than 40, she could only be randomized to 400 or 2,000. And if her initial baseline level was greater than 60, she could only be in the 400 IU group. We evaluated monthly safety, efficacy, effectiveness. We measured 25 hydroxyvitamin D, 125 hydroxyvitamin D serum calcium, creatinine, phosphorus, and urinary calcium creatinine levels, because the thinking is that if you have too much vitamin D, you start spilling, you elevate your calcium, your body is trying to adapt to that. So you start spilling calcium in your urine. So that would become the first indicator of vitamin D toxicity. Everyone, investigators, our participants, our health team, we were all blinded to treatment. And the only individuals who knew the treatment group were the investigational research, our pharmacy, and the head of our the biostatistician who was in charge of randomization code. So our primary outcome was to determine the most effective and safe oral vitamin D daily supplementation dose to achieve vitamin D sufficiency throughout pregnancy, starting at 12 to 16 weeks. Sufficiency was defined a priori as total circulating 25 OHD of 32 nanograms per ml or 80 nanomoles per liter. And you can see that there was a dose effect. So really, we saw no real increase. We certainly saw, you can see the 400 IU group, there was a slight increase because the majority of the women at baseline were not taking any vitamin D. And we see the 2,000 and 4,000. So there was a dose effect across the three major racial ethnic groups. What we see is that if we define deficiency less than 32 nanograms per ml, we see that really 400 IU per day was really irrelevant in decreasing the rates of deficiency. We saw 2,000 was more effective, and 4,000 IU a day was most effective. And when we looked at neonatal deficiency percentage by maternal treatment group, again, we see a dose effect. So if we defined it less than 20 nanograms per ml, we see the 4,000 IU group had the most effective, it was most effective in decreasing neonatal deficiency. However, 20% of those neonates met the criteria for deficiency, because if you were non-adherent to protocol, you were still included in that group. But we certainly see that there is a dose effect. Then we did another study, and it was called the Thrasher Research Fund Pregnancy Study. And when we did at baseline, looked at what were the factors that really influence vitamin D status during pregnancy. Age and gravidity were not significant in the model. Seasonality, slightly. BMI, so if you had a higher BMI, of 30 or greater, you were more than 2 times more likely to have vitamin D deficiency. If you were Black American compared to white Caucasian, you were 20 times more likely to have vitamin D deficiency. And if you were Hispanic versus white Caucasian, you were 2.4 times more likely. And that was published in 2011. Just to review, we know the actions of 1,25-OHD in general. This active hormone inhibits PTH, promotes insulin secretion, inhibits adaptive immunity through T-cell interactions, promotes innate immunity by acting through toll-like receptors on monocytes and macrophages. For example, enhanced production of cathelicidin LL37, which is an antimicrobial peptide. It also inhibits cell proliferation, so plays a role in cancer, and it stimulates cellular differentiation. What about during pregnancy? Oh my gosh, it is really fascinating, right? So I mentioned earlier, within days of conception, 125 starts going up by 10 weeks. It's more than double what it was during the non-pregnant state. And in most pregnant women, it's more than triple what it was before pregnancy by the end of the first trimester. If you had those same levels in non-pregnant individuals, it would be toxic. They would be hypercalcemic. And while it's synthesized by placental decidual cells, its main source is kidney. And the 1-alpha hydroxylase is somehow released from control of parathyroid hormone during pregnancy. It's independent of calcium homeostasis. And so we know that by studying thousands of pregnant women, that PTH is not driving this massive vitamin D metabolism normally seen during pregnancy. As I alluded to, we really think its role during pregnancy is involved in tolerance to prevent rejection of the fetus. But even in 2025, we have many unanswered questions. So this just shows you, and this was published by Dr. Walker in 2011, looking at the relationship. So the same graph could be superimposed for mother, looking at the relationship between 25 hydroxyvitamin D on the x-axis and 125 OHD and dihydroxyvitamin D on the y-axis compared to adults. You see no relationship, but a very strong, an R of 0.78. And that's the same relationship that occurs in both the mother, the pregnant woman, and her fetus. And so those are startling effects, and yet moms and the fetus do not have hypercalcemia. And again, let's look at PTH during pregnancy. Doesn't change, and it didn't change by treatment. We see there's an upswing because we had fewer women at the 40-week cut point. We see this is the PTH as a function of circulating 25-OHD, and really you do not see PTH driving vitamin D metabolism during pregnancy. And then this was really startling. This is really the curve that is telling us what is optimal vitamin D status during pregnancy. What we see is 25-OHD had a direct influence on 125 dihydroxyvitamin D levels throughout pregnancy. And it does not occur at any other time during the lifespan. And what we see is first order kinetics becoming zero order kinetics. In other words, at around 100 nanomoles per liter, which is 40 nanograms per ml, you see a leveling off, so that's a threshold effect. And that's the level to optimize the conversion of 25 hydroxyvitamin D to 125 dihydroxyvitamin D. And that has been shown in other, by other, research groups. If we looked at adverse events throughout the study, we found no differences between the treatment groups on the basis of circulating 25 OHD level, serum calcium, creatinine, urinary calcium creatinine ratios. So there were no differences between the three treatment groups. And there was not a single adverse event attributed to vitamin D supplementation by an independent data safety and monitoring committee that reviewed data quarterly throughout the study. And when Bruce Hollis, who was the PI on this study, and when he presented these data, these were startling findings, right? They really, the status quo, the concern that vitamin D at 4,000 IU a day was going to be a teratogen, cause fetal abnormalities. That was the concern. And yet there was not an increase. And then when we looked at the data more carefully, we actually saw that the women who had a level of at least 40 nanograms per ml, and I'll show you data in a minute, had a less risk of preterm birth. My colleague, Bruce Hollis, published this study in 2011, and again, on a follow-up of the data in 2013. The primary outcome, looking at both the primary and secondary outcome, the conclusion from this study was that vitamin D supplementation of 4,000 IU per day for pregnant women was safe. It was effective in achieving sufficiency in all women and their neonates, regardless of race. But remember, when we look at 20% of these women did not reach sufficiency, and that's what happens when you look at treatment as opposed to levels or the biomarker 25 OHD. Because if a woman's non-adherent to protocol and she's not taking her vitamin D, she's lumped in with those who are taking it, and so it's diluting. If you're only taking 400, it doesn't really matter so much. It's less of a treatment effect. And it's magnified those women who are not being compliant. The discrepancy in outcome is magnified. The need for longitudinal follow-up. So vitamin D is a potent precursor to an elaborate hormonal system that impacts not only calcium homeostasis and bone metabolism, but also has effects on both the innate and adaptive immune systems, and it must be considered a driver in the developmental cascade of life. Looking at the long-term effects of vitamin D deficiency on childhood health, development, and immunity is essential. Are there critical windows in fetal and early childhood that define vitamin D's effect, during which times there is more harm associated with deficiency? We can maybe address some of these questions, but we don't know. We need to continue to study this. And really, for the last 5 years, vitamin D was the stepchild. And there was a lot of, I would say, disparaging comments about, vitamin D really isn't important. Yet, if I told you that someone was on a pre-pro hormone like thyroxine, right? And you didn't check levels, that would be considered malpractice. With vitamin D, it's being lumped in as a nutrient. And so I think we have to be really careful what we advise. Another study that we performed in South Carolina, the Thresher Research Fund funded it. It was community-based vitamin D supplementation, and we published that in the American Journal of Obstetrics and Gynecology in 2013. We recruited from 2 community health centers in South Carolina. We were limited in what we could do, so we had to measure their baseline level. So they all got a run-in dose of 2,000, and they were randomized to either get, for the first month, and they either got 2,000 or 4,000. The concern by our our institutional review board for safety was that 75% of the women had profound vitamin D deficiency, and that that they should not be randomized to the control group of 400. So these women were randomized to either get 2,000 or 4,000 international units a day. We monitored monthly for hypercalciuria and bi-monthly for hypercalcemia and change in renal function, serum creatinine. And what we found was that both 2,000 and 4,000 was associated with improved maternal and neonatal vitamin D status compared to their baseline, and that 4,000 was better in both the moms and their babies, their offspring. Safety data, what we found was that in those women, looking at 25 hydroxyvitamin D concentration, that they actually had a reduction in the risk of preterm labor and preterm birth that persisted even after controlling for race. So for every increase in 25 hydroxyvitamin D concentration by 10 nanograms per ml, preterm birth risk decreased by half. So you can see the odds ratio. And in that paper, I didn't list it here, the confidence interval. And for every increase in 25 OHD concentration by 10 nanograms per ml, preterm labor or preterm birth decreased by 28%. Again, the odds ratio was 0.72. There were no adverse events associated with vitamin D supplementation, again, on any of the parameters that we that are the classic measures and monitoring of safety. When we combined our NICHD and our Thresher Research Fund trials, we had a common data dictionary. We were using the same manufactured lot of vitamins, so we were able to utilize the control group of 400, and we had the treatment group of 2,000 and 4,000. We also administered the same questionnaires to produce comparable sociodemographic and clinical characteristic analyses. Our outcome measure was maternal and neonatal 25 OHD achieved, maternal comorbidities of pregnancy. We looked at hypertensive disorders of pregnancy, including preeclampsia, any infection, preterm labor, preterm birth without preeclampsia. And what you can see here is that when we combined the comorbidities of pregnancy and looked at their final 25 OHD level, we saw an association. So in women, again, as I mentioned earlier, in women with a 25 OHD, here's the confidence level interval 0.74 to 0.96, the odds of having a comorbidity were lower. And when we used the cut point of 32 nanograms per ml or 80 nanomoles per liter as our a priori definition of sufficiency in both trials, what we found was really you had, if you achieved a level greater than 32 nanograms per ml or greater, you had a lower risk of preeclampsia, hypertensive disorders of pregnancy, any infection, and overall any comorbidity. You saw really the number needed to treat was substantial. And this is really the lowest curve of the 25-hydroxy vitamin D looking at gestational age. And what you see is that inflection point at 40 nanograms per ml or 100 nanomoles per liter. Very much so in the combined data set, we see that again. If we look at it by race ethnicity, we find similar, comparing to the March of Dimes, the published March of Dimes rates, we see that those women who had achieved vitamin D sufficiency, we see across the race ethnicity a decrease in the preterm birth rates. When we looked at, in another study that we conducted, the Kellogg pregnancy study, when we looked at cytokines, these women were randomized to 400 versus 4,400 IU of vitamin D3 a day, starting at 10 to 14 weeks of gestation, followed to delivery. What we found was that baseline 25-OHD impacted later immune profiles, and that these baseline growth factors, interferon alpha, C-reactive protein, TGF beta, TNF alpha, sorry, VEGF, IL-2, IL-4 were associated with concentrations at the second and third trimesters that were for these respective immune mediators, but 25-OHD was not. And so, in other words, it seems that the trajectory that really that first trimester and achieving vitamin D sufficiency early on affected later immune expression. And there were some racial ethnic differences in these concentrations as well. When we looked at placental gene expression, what we found, and this was published in 2017, we really, and just if you want the methodology, I'm just going to skip over that, but it's just here for your, looking at punch biopsies within very well delineated methodology. Standardization of the techniques that were applied. The laboratory was blinded to maternal 25-OHD status and treatment group. And what we found was, you see that there was upregulation and downregulation of some key growth factors that are associated with VEGF. And you can see that placental IGF, VEGF, and S-FLT were affected. So the conclusions from these placental analyses was that there was an association between maternal 25-OHD reaching a threshold of 40 nanograms per ml or greater. We saw a decreased gene expression of VEGF, which is implicated in the vitamin, in preeclampsia, and we also saw a reduction in gene expression of S-FLT. And the association may demonstrate a vitamin D3 supplementation impact on gene transcription in the placenta. And this was the first report of this association. By treatment group, we certainly see that there's a dose effect. So those who were on 400 versus 4,400, much more replete in the 4,400 IU group, but there was no difference in serum calcium and really very little difference in urinary calcium creatinine ratio markers of safety. When we look at genetic and epigenetic data from the Kellogg pregnancy study, again, we saw an effect on gene expression in the placenta. We also saw epigenetic clock differences, and that vitamin D3 supplementation decreased the gestational age acceleration. And in the African American participants, and that vitamin D supplementation may slow down the epigenetic gestational aging process in the African American neonates. We also looked at immune data from the Kellogg study and Kellogg vaginal microbiome data. We saw that certain vaginal bacteria were associated with maternal plasma 25-OHD concentration, and I showed you the data that was published in Pediatric Research in 2020 on the cytokine data. So conclusions from our Kellogg project was that vitamin D supplementation in all the trials at doses of up to 4,400 IU a day of vitamin D3 was safe and effective in raising the circulating 25-OHD concentration. It impacted African American women in the US and women with profound vitamin D deficiency in other countries, which obviously we didn't measure in the Kellogg, but has implications for them. And it certainly could explain the higher rates of adverse events during pregnancies in these groups. That vitamin D status has far-reaching implications on immune function and gene expression in the pregnant woman and her developing fetus, as evidenced by changes in vaginal microbiome patterns, cytokine profiles, data that I didn't show here, T regulatory lymphocyte phenotype, and placental gene expression. Such findings should inform future public health policy surrounding pregnancy interventions for these most at-risk women. And just to show you, again, the combined data looking at gestational age, and we see that those who are vitamin D deficient are more likely to have earlier gestation. That doesn't mean if you're vitamin D replete, you're not going to have a preterm birth. We're talking about risk. And again, another showing this is work that Grassroots Health helped us analyze, looking at a reduction if a woman had achieved a level of at least 38 nanograms per ml, which again, the optimal conversion of 25 to 125 dihydroxyvitamin D during pregnancy is around 40 nanograms per ml or 100 nanomoles per liter. And again, reminding you of this threshold effect. So we really feel that vitamin D deficiency during pregnancy, we know that if a woman takes 4,000 to 4,400 during her pregnancy, that she's going to have a really robust vitamin D status. And that women who achieve a level of around 40 nanograms per ml or 100 nanomoles per liter are more likely to have fewer adverse events during pregnancy. And this was also confirmed in the VDART study, which was out of Harvard. Scott Weiss and his group, Gus Lutanja, and really some absolutely elegant work has come out of their studies. We know the Denmark study also recapitulated, showing no toxicity, and that really while they didn't have a statistically significant decrease in persistent wheeze, they did see immune differences. The Iranian study, you really see much more profound vitamin D deficiency. And if women were dosed 400 IU a day versus 50,000 IU orally every 2 weeks, they really saw a difference in gestational diabetes. a very important study that was published in the Iranian Journal of Reproductive Medicine in 2015. Another study by Sabluk et al. That came out in 2015 that showed even if you begin vitamin D supplementation at 20 weeks of gestation, they saw fewer complications such as gestational diabetes, gestational hypertension, preeclampsia, and preterm deliveries. I mentioned the Kellogg study, and what we found was that in our Black American women had worse outcomes. And if we looked at the 25 OHD, the area under the curve, what we found was the lower 25 OHD area under the curve was associated with more likely to have non-repeat cesarean delivery compared to those who delivered vaginally, and that those who had a lower area under the curve were more likely to have had hypertensive disorders of pregnancy. When we looked at our own data for the last like around 9 years, in 2016 to March of 2024, a retrospective analysis, we hypothesized that 25 OHD concentration would be significantly positively correlated with gestational age. And we excluded any women with cancer, HIV, or who were participating in one of our vitamin D supplementation trials during in this retrospective analysis, and we compared 25 OHD concentration and gestational age at delivery. And what we had a good distribution of race ethnicity. Overall, we had an increase over the time period. This was presented actually in at pediatric academic societies, and it will be presented in June, this June 2025, at the Vitamin D workshop. It was also presented at the Darby Children's Research Institute Research Day on May 8th. But what you can see is that mothers delivering less than 37 weeks had significantly lower 25 OHD compared to 30.4 compared to those who were 37 weeks or more at delivery, 34.8 nanograms per ml. And the difference was accentuated among moms delivering less than 32 weeks of gestation. So you see 26.3% compared to those who were delivering 32 weeks or greater. And you can see, and these findings were consistent across the three major racial ethnic groups. And again, you can see the differences and the mean difference, the confidence interval, and so forth. And you can see this graphically. If we look at those who had a level less than 10, 22% delivered, that's nanograms per ml, 22% delivered before 37 weeks, compared to those who 12.7% who had a level greater than 10. If you looked at less than 20 versus greater than 20, and you can see the demarcation, the relative risk, and here are the confidence intervals. So conclusions from this retrospective analysis was that really those moms delivering before 37 weeks had significantly lower 25 OHD concentrations as the indicator of vitamin D status, and the difference was greater for women delivering less than 32 weeks. And it suggests a potential dose-response relationship. The risk of delivering less than 37 weeks increases as 25 OHD concentration decreases. So there's an inverse relationship, which we've seen in our other trials. And we really need to, you know, really future research should be conducted to determine a causational relationship between vitamin D status and preterm birth. The findings suggest that 25-HD screening and supplementation could be a cost-effective preventative strategy to lower the risk of preterm birth. But still, being vitamin D replete does not ensure optimal health. So what more can we do? And remember, when we talked about, the 6 pillars of health, what can we do? We certainly need to look at vitamin D status, but do we ask pregnant women, how's your sleep? What's your stress level? Are you exposed to certain environmental toxins? Do you have a higher BMI? Are you walking? Are you even in a safe neighborhood to walk? And what about your diet? Other modifiable factors that are affecting maternal, fetal, and neonatal health. Influence of stress. I don't have time to really go into that, but we learned that stress during COVID really influenced rates of preterm birth. And we really need to pay attention to that. We certainly know that was not seen in the United States, but in other countries, that during lockdown, it affected preterm birth worldwide. Other modifiable factors, diet, hugely important. Are we asking our pregnant women, our lactating women, what's your intake of vegetables, fruits, legumes, nuts, whole foods? Trying to risk cardiovascular disease. There are certain foods that are very inflammatory. Is that playing a role with placentation, vasculitis, leading to preeclampsia and adverse pregnancy outcomes? And are pregnant women having lots of sweeteners? Are they having lots of animal fats, vegetable oils that are pro-inflammatory? Looking at industrialized countries and the intake of breads, desserts, salty snacks. What's her sodium intake and what effect does that have? Really pay attention to diet, exercise, sleep, stress, environment, all of those factors. These are really, really important. And again, if a woman's vitamin D deficient, I can tell you that she's going to have some of these other risk factors. And we should be paying attention to the whole package. So really, how's a pregnant woman sleeping? Are we paying attention to exercise and physical activity as well as diet? So many factors influence maternal health and pregnancy outcomes. Vitamin D status, we certainly know, plays a role in maternal health and pregnancy outcomes, fetal health, later neonatal. So if you're vitamin D deficiency, then you likely have other risk factors for suboptimal health. I view vitamin D deficiency as the canary in the coal mine. If you are vitamin D deficient, you are likely to have other risk factors. Again, as I mentioned, I don't want to sound like a broken record, but are you sedentary? Do you exercise? Do you eat enough fruits and vegetables? You should, have your helping of 6 fruits and vegetables a day. Stay away from foods that are inflammatory, such as animal products and saturated oils. Do you live in a food desert? Do you sleep enough? What is your environment like? Are you exposed to air pollutants, noise pollutants, other toxins? Are you in a stressful, unsafe environment? Maybe you can't walk or exercise because you can't get out your door. So how do you, as a healthcare provider or an informed person taking control of your own health, how can we discuss what's associated with better health for you, your patient, your relatives? Sharing clinical trial data, know the strengths and weaknesses of systematic reviews and meta-analyses. Equating treatments, leaving out control groups, because we all know some really elegant studies have been conducted in industrialized countries, high-income countries where, control group was 400 IU a day. Don't throw those studies out. Those are compelling studies. And we really should have an individualized approach for each patient. One size, one diet, one lifestyle does not fit everyone. And the importance of discussion and sharing the responsibility, the person, the care provider. It's a dialogue. It's time consuming, but an ounce of prevention is definitely worth the pound of cure. Do you practice what you preach? Right? I absolutely think that's essential. So as a patient, as I mentioned, take control of your destiny, your own destiny and health, embrace responsibility for your health, seek out small changes to improve your health trajectory. Maybe you don't want to have, 10 vegetables and fruits a day, but let's increase it by 1 or 2 a day. Eat better, be active, and look at factors that you can more easily modify. Be kind to yourself. Even small changes like becoming vitamin D sufficient will help your overall health status. I can't emphasize that enough. And, have compassion for yourself and others. And really, that's the end of this talk. And I hope that I have shared with you some compelling reasons to be vitamin D sufficient and to care about your vitamin D status. I welcome any questions that you might have. Feel free to reach out to Grassroots Health, direct any questions to me. I really, really feel like asking those questions is going to help you be empowered and take control of your own health. And I really wish you a wonderful, wonderful rest of the day. Thank you so much for listening.